PTAs. Hope you guys are doing well. I said hello, but I don't think it was recording, so hello. Today we're going to talk about cerebral palsy, chapter 6 of our textbook. So the definition for cerebral palsy, and I got some of this out of the Score Builders book as well, is an umbrella term. It's used to describe movement disorders related to brain damage. It is not progressive, so it doesn't get worse over stages in life. Initially, you have whatever damage it's caused, essentially, and then throughout life, you're dealing with how to gain function with that damage. So it decreases the brain's ability to monitor and control nerve and voluntary muscle activity. So it could just affect the patient's movement, but it could also affect their cognition, depending on what caused the cerebral palsy and how severe it is. There are various causes: prenatal, perinatal, and postnatal. So prenatal, that's while the parent was pregnant, while the mom was pregnant. Some of the causes of that could be placenta abnormalities, toxemia, drug and alcohol abuse, maternal infections, anything that causes decreased oxygen to the brain or the fetus not to develop correctly could cause some cerebral palsy. Another thing that I have seen diagnosed recently that wasn't diagnosed years ago is a stroke in vitro, where the fetus had a stroke while still developing in the womb. And so that is also a possibility for prenatal. Perinatal, some of the causes, there's plenty, but are premature birth, prolonged birth, RH incompatibility, essentially anything that causes stress to the baby while being delivered or causes decreased oxygen to get to the brain while in delivery process. And then postnatal, after birth, the child can still develop cerebral palsy if there is something pretty soon after birth that causes damage, like meningitis, swelling to the brain, a stroke, seizures, some type of brain injury right after birth, then it could still cause cerebral palsy. Some studies actually suggest that there are ways to prevent or decrease the likelihood of your child developing cerebral palsy. Most of those focus on giving the mom magnesium sulfate either during the last 8 weeks of pregnancy, like from 32 weeks of pregnancy on, or sometimes even while they're in labor. They suggest just giving that magnesium sulfate, and the studies say that it has reduced the risk of potential seizures and of cerebral palsy in children that are at higher risk. Another therapeutic treatment that they have studied is therapeutic hypothermia, so decreasing the baby's body temperature right after birth. And they have also found that that can decrease risk of seizures or cerebral palsy in people who are born with asphyxia, so hypoxic ischemic encephalopathy, basically low blood flow to the brain. If they had a point where there wasn't enough oxygen reaching the brain and you do some cooling of the child, hypothermia, to therapeutic likelihood of getting brain damage, essentially. Some of the signs and symptoms, they vary from very mild and undetectable to severe, even loss of control. There can even be profound intellectual disabilities, just depending on the severity. Abnormal muscle tone is one of the common impairments, impaired movement, modulation, presence of abnormal reflexes, impaired mobility. So it can really vary greatly depending on the child. It's common to see spasticity in specific movement patterns. So similar to a stroke, where you see a lot of flexor spasticity in the arms and held in that synergy pattern. It's very common to affect one side of the body. It could affect both. We'll go over that in a minute. But it Also, it's common to have, of course, gait abnormalities, scissoring gait, often tight hamstrings, so decreased knee extension while standing or while walking. And again, it can be different in every child, so the symptoms are vary greatly. How we classify it is by the distribution of involvement, which we'll talk about in a minute, which limbs it affects, by the amount of abnormal muscle tone and the movement, by if there is spasticity or not. Remember, spasticity is that velocity dependent increase in muscle tone. If there's transient dystonia, um, transient dystonia is actually a condition where the child presents as if they have CP, but those symptoms resolve within their first year of life. So sometimes somebody might be diagnosed and then their symptoms may completely resolve. And in that case, it was likely transient dystonia. So it's a little bit difficult at first to differentiate that. Rigidity is another way that we classify cerebral palsy. So rigidity is that increased muscle tone to the point where any movement in any direction is difficult. And of course, it's not velocity dependent like spasticity is. Dyskinesia, this is disordered movement. It includes a lot of different disordered movements like dystonia, athetosis, chorea. It could have a mixture of several of those. And then ataxia, that's the loss of coordination. And when we talk about ataxia with gait, then it's an uncoordinated gait. So this is what we're talking about when we talk about the distribution of involvement, which extremities are involved. So monoplegia only affects one extremity. Hemi is half of the body, just like with what we commonly see with strokes. Diplegia is two extremities. Typically, it's the lower extremities. The upper extremities may or may not be affected. So in this case, like if the legs were extremely affected and the arms were just slightly affected, then you might consider it diplegia versus quadriplegia, which is when all four extremities are affected. All of these talk about plegia, which is paralysis versus paresis, which is weakness, but keep in mind that some of this is weakness. It could be weakness in the extremities, not just paralysis, and could still be cerebral palsy. The Gross Motor Function Classification System, which is shortened to GMFCS, is one of the ways that they classify the level of severity of cerebral palsy. And so there are 5 levels ranging from very mild to very severe. And the most independent level, level 1, typically ambulatory and moving all extremities, versus level 5 is the most severe and is typically wheelchair bound, likely to require power mobility. And the 3 categories that we look at to determine that gross motor function classification is their mobility, their hand use, and their communication. And we as PTs typically aren't the ones determining this. This is a physician that's determining their level. But we can recognize what level they're at and let that kind of lead our therapy. So here is just a little snippet of how the scale looks for children between ages 6 and 12. So where level 1, they're able to independently carry an object, walk up and down stairs without hand support. And then level 2, they need some hand support or they're a little unstable, versus level 3, they need some type of assistive device, but they're able to still move independently. They don't need anyone pushing them. Level 4, they may need power mobility, but they're able to do it independently, or they may walk some, but they need a little assistance from another person. And then level 5 is more dependent mobility. They need someone else to move them from place to place. Very similar with children ages 12 to 18. As far as the levels go, 1 is the most independent, 5 is the most dependent, but just different expectations for what they may or may not be able to do at that point and how we grade them. So there are primary motor patterns seen in cerebral palsy. The two are spastic or athetoid. The first one, spastic, is a lesion in the motor cortex of the cerebrum, so upper motor neuron damage. Spastic has more tone involvement, so a lot of tightness in the muscles and contractions when they're not telling their brain, or their brain is not telling their body to move or to contract. And then athetoid is typically when there is a lesion in the basal ganglia. And these patients have a lack of postural mobility. They may demonstrate large, uncompensated body movements around a long axis of the body to provide additional stability for functional things. So they may also use abnormal postures for stability. So sometimes you may see them like writhing their neck in order to grab something because they're just trying to pull every muscle in to work that arm and aren't able to selectively dissociate those muscles and use the muscles they're just trying to use. So if they're reaching out for something, they may pull that everything on that side of the body in to try and get it because they're not able to turn some muscles on and keep some off. So one example I gave is, think about when you're, for women, if you're putting on mascara and you find yourself like opening your mouth to put on, nobody can hardly put on mascara with their mouth closed. It's like you're just pulling in all of the muscles in your face to concentrate on what you're doing to do that task. And it's a similar type of concept where, they're focusing so hard on moving that arm for whatever functional movement that they're pulling all the muscles in that area. All right, some of the other deficits, there can be feeding and speech impairments. Typically, as PTs, of course, we are not focusing on feeding or the speech impairments, but we may focus on positioning so that they're able to eat better or breathe better. So although we may not directly work on feeding or speech or breathing, although we can work on some breathing, oftentimes if they're in a better position and if they have more core stability and if they have more head control or more hand dexterity or any of those things, it will help them with those tasks. So we still work on things that help them with those. Another associated deficit, so intellectual or cognitive disabilities, seizures are common with people who have cerebral palsy, visual impairments, hearing, speech, language impairments. All of these can be common depending on the severity. I sneezed during every one, huh? All right. Common patterns: a child with spastic cerebral palsy typically moves slowly and with difficulty. One reason why they do that is because there's muscle co-contraction. So remember, there's that agonist-antagonist muscle relationship around a joint. So while one muscle group is on fire or firing, the other muscle group should be getting a signal to relax. Okay, it's inhibiting muscle movement. So while one is saying contract and shorten, the other is saying relax and lengthen so that we can shorten and move the opposite way. With cerebral palsy, oftentimes both muscle groups are firing at the same time. So while your brain is saying, hey, bend the arm to give me that food, your muscles are firing in both directions. So it's like a fight, like, who's going to win? The triceps and biceps are firing at the same time, and you can see shaky movements as they're trying to do something because they're fighting against an active muscle group versus an inhibited, relaxed muscle group. And you can imagine if every time you move to do something, you were fighting against an active muscle contraction pushing you in the opposite direction. Fatigue is huge in these patients because they're constantly working doubly to do the same task. So something that we could easily just grab something and bring it here, well, they're fighting against the opposite muscle group in order to do that. And so they're having to work twice as hard. So fatigue is really common. There are stereotypical patterns of movement. Put this picture on here because of the scissoring. You can see where his legs are really crossed over in the middle. That is a stereotypical pattern of movement. So again, their bodies typically with the spasticity bring them into synergy patterns similar to that of someone who has hemiplegia related to a stroke. and it can cause scissoring gait, and it can cause the arm to be in a kind of a flexed pattern, and other stereotypical patterns of contraction. Now, I just talked about the muscle co-contractions and fatigue. Most people with cerebral palsy will reach their gross motor ceiling capacity by age 5. So essentially, if they're going to walk, they will likely walk by age 5. And if by age 5 they are not walking, it is less likely that they will start walking later. That's kind of what that means. So the patients may be restricted in social interactions, in peer play, in school, in dating, in future job opportunities. It could affect their entire life. And it depends on the severity. It depends on the therapy they get. It depends on their family support. It depends on so many categories that we just can't determine. But keep in mind, the more function you give them, especially earlier, the more it will positively affect their entire life. Often people with cerebral palsy demonstrate obligatory tonic reflexes. So that is where a reflex dominates the child's posture and it interferes with their adaptive movement. So it can lead to impaired balance and minimal selective motor control. So difficulty balancing, difficulty doing intentional tasks. So you're trying to reach with this arm and the whole body is kind of reaching. Because you're using a reflex. You look down to do something and the reflex pattern takes over and everything bends or everything, extends when you drop your head, just depending on which reflex is the dominant reflex that's kind of directing their movement. So it could make it harder for them to do intentional movements and selective muscle groups. Let's use the biceps only and not also the triceps or the deltoid or the upper trap. Let's not bring everything in. Let's just bend one thing. It's a lot harder to do that when reflexes are directing your movement. All right, now we're going to talk about some treatment for children with cerebral palsy. So the book kind of broke it down into 3 stages. From birth to 3 years, from 3 years to adolescence, and then from adolescence to adulthood. And really the 4th stage was adulthood. And that's fine. Really, just like I've told you with every patient population, you treat what you see. I mean, it's cool that we can break it down and kind of get an idea of what to expect or an idea of how to move and how to progress somebody as they age. But ultimately, if they are 2 and they're already at this level, you don't wait until they're in adolescence to start something. You do it when they need it and how they need it, just depending on their functional abilities and their needs. So in the first 3 years, typically early intervention, number 1. Early intervention is key, whether it's speech therapy, physical therapy, occupational therapy. The earlier you get treatment, the better it is for your whole life. Because if you learn in good, if you develop good habits, you keep good habits. If you learn how to walk with a good, nice, normalized gait pattern, then you're going to continue to walk that way. If you learn how to walk with significant changes, with significant defaults or gait abnormalities, then you're going to have a lot harder time breaking them after you've been doing it for years. Okay, so early intervention is huge. The more therapy they can get at an earlier age, the better they're going to be set to do things later in life more independently. Of course, the first 3 years, it's family centered. I mean, the family really has to do most of it. If you're seeing the patient 2 or 3 times a week, that's not enough. It's not enough, but no insurance company is going to pay for more. So you need to teach the parents what to do so that it is enough. And again, just like in our positioning and handling PowerPoint, keep in mind, these parents are overwhelmed. Every parent should be overwhelmed. It's just an overwhelming thing to be a parent, especially a new parent. If you have 5 kids, maybe at this point you're used to it and you're not thinking too much into it, but your first kid or 2, it's overwhelming. Speaking on my own, 4 is also overwhelming. So I don't know about 5, at least not babies. And so what you're doing is trying to just teach them how to incorporate therapeutic positioning or stretching or ways of provoking strengthening exercises, or ways of sitting them down and positioning them to provoke more strengthening and more core control, or whatever the goals are throughout their daily life. So you're not giving them a home exercise program that says do 20 of these 3 times a day. Don't. But you can give, every time you're doing a diaper change, stretch their hip adductors. Every time you're holding them, switch sides so that they're not always looking to one side. Or if they have neglect of one side, like the left side is weaker, then maybe you hold them on a side so that they're using their left more and they're looking towards their left more. So just being intentional about how you're doing the things that they already have to do. So you're not giving them more work. You're just changing the way they're doing what they're already doing so that it's more therapeutic. Okay. That's huge. That they can do. Adding more work, not so much. Focus on proper handling, positioning, feeding, and respirations. Again, we don't really assist directly with that, but we can educate them on deep breathing. We can actually place a little pressure on their, I can't show you because my camera's not showing below my my rib cage, but place a little pressure on the rib cage, and you can add just like a very slight, and remember they're little, so very little pressure to the rib cage right before they inhale to kind of activate that recoil to help them inhale more and get more deep breathing, more diaphragmatic breathing. You could place them in different positions, side lying, sitting, supine, to help them breathe and just focus on taking a deep breath. Typically with children, it's even harder to do this, but one thing that you could have them do is tell them, like smell the roses, blow out the candles. So deep breath, smell the roses, blow out the candles. But if that's not working, you might actually get something that smells and be like, smell this, take a big whiff, and actually trying to do it that way. It's a little harder at 0 to 3 years to get them to do what you're trying to do. You always want to use a variety of positions, and switching positions every 15 minutes or so is ideal to help them really interact with their environment and work on different muscle groups and not get overly fatigued. You want them to help them explore their environment, help them find their toes or bring their hands together, reach for objects, tolerate different positions. Encouraging all that is huge. Encouraging play at this age is huge. And helping them using different therapeutic exercises to help them develop their motor skills. Constraint-induced movement therapy, that was originally developed more so for people who had had strokes, and now it's used often with people who also have cerebral palsy. And so with children, typically what they'll do, and that's that bottom picture. I know he's not quite 0 to 3 years, but that's that picture where they put a cast on the uninvolved arm in order to provoke more movement and intentional function with the involved side. So typically the cast is worn all day. I liked in this picture that the cast he had on you could remove, which would be nice because some of them you can't. And remember, when you immobilize something, there are negative effects of immobilizing it. And what you don't want to do is make the unaffected arm weaker. But your brain actually, when you're not using that arm for the majority of the day for 6 weeks at a time or 8 weeks or however long, then your brain actually develops more pathways for the involved arm and really connects some areas that maybe weren't connected before, because it's kind of forcing you to use it and it's forcing your brain to pay more attention to it. And there's been a lot of positive effects of constraint-induced movement therapy for people with strokes and with cerebral palsy. Another thing in the first 3 years, so you're wanting to encourage sitting and standing as much as they are able. Encourage independent mobility, again, as much as they're able. You can do ambulation training. So typically ambulation is predicted by the child's ability to transfer from sitting to standing at an early age. So if they're able to transfer from sitting to standing, then most of the time you think at some point they probably will be able to walk. If they're not able to help with those transfers at all, then it gets less and less likely that they'll develop that skill eventually. Early mobility is the key. period, even if it's power mobility, even if it's wheelchair, even if it's just scooting on some type of a device that you've made for them that rolls around, whatever they can do, exploring the environment independently is huge in the development of a child. And the earlier, the better. So if they are not walking by a year old, you need to get some type of device where they're able to pull themselves around, or they're able to, you know, push a button and roll around, or whatever can happen to give them some independent mobility so they can start to explore their environment. A body weight supported treadmill, that's the bottom picture, can be used to help take extra pressure off the muscles and do what they can do and help with walking without making it strenuous on the body. So many children with level 2 cerebral palsy will walk by age 4 to 6. Again, we talked about oftentimes if they're going to walk, they typically will walk by age 5. However, some of them may still need assisted devices, and that's fine. Level 3, okay, sorry, I didn't read it correctly. So level 2, typically by age 4 to 6, so around 5, walk independently without an assistive device. But level 3 will typically start to walk by age 4 or 5, but may still need an assistive device. That's what I was trying to say. So hopefully you understand level 2 can typically walk without an assistive device by age 5, essentially. And level 3 often walk by age 5, but may need an assistive device. All right, second stage is preschool period. You're wanting to encourage independent mobility, work on gait training, increase their physical activity, their movements, their ability to help with their ADLs. Those are your activities of daily living. You want to promote social interactions as much as possible, help them learn how to play with peers and put them in settings where they're able to play with peers. In that top picture, she's playing with a peer. The peer kind of got cut out of the picture, so hopefully you can see that. Being at eye level with peers is huge. Promote communication, promote learning, use orthotic devices whenever needed, braces and assistive devices as much as needed to help them be as independent as possible. Third stage is school age to adolescence. You're helping them to take more and more responsibility for their own therapy and their own goals and their own life choices, helping them stay motivated. Remember, there are a lot of physiological changes happening in this time. Most of them are hitting puberty, they're having growth spurts, their body is changing, and so are their needs. And so you do want to promote a positive self-image, but also in this stage, there is a lot of caregiver training needed, because when the child was smaller, oftentimes the parent could just pick them up and haul them over wherever they needed to go. You know, when you have an infant, you don't like use a sliding board to transfer them. You just pick them up and put them where they need to go. But when you have somebody that's 12 and is now 100 pounds, it's hard to just manhandle them and put them in and out of their seat or in and out of the car. And so oftentimes what I have found is that, you know, before their child starts to go through puberty, they're just picking them up. They're not doing any transfer technique. They have no interest in learning it. And then all of a sudden, the parent starts having some back problems because they're picking up 100-year or 100-pound child over and over throughout the day, and they're like, I gotta have some help here. And so then they're willing to learn a sliding board transfer, or even, you know, just dependent transfer techniques where they're using their body to help them rather than hurting their body to help someone else. And one thing that I say to caregivers all the time, because so many times they get in this mindset of, I have to do whatever it takes for my child, and that's beautiful and that's great. But if you're not healthy, you can't help them. If you hurt your back, you can't move them. If you are down and out and just broken because you've given them everything, then you're really not much good for them. So you've also got to take care of yourself. And that's a hard conversation to have, but I've had that with many caregivers because they care so much about their children that they feel guilty if they take any time for themselves, or they feel guilty if they can't provide what they think they need, and feel guilty asking for help. But always encourage them, take the help, get some help, and let someone help you, let them train you, let them come in and help for a few hours while you go and get groceries or do some of the things you need to do for the house. So that is something I find at this age is really key for caregivers, is kind of letting the child get more independent, but also taking care of themselves and learning the true skills of transferring and of bed mobility and all the things so that they can continue to provide the level of care they need. You want the patient to develop as much independence as possible in caring for themselves, but you also want to encourage just lifelong fitness, how to develop strength and how to get into a fitness routine, how to um, participate in sports activities or in hobbies or in whatever social things that they like to do. Um, so encouraging that is huge. Another thing about growth spurts is that oftentimes the muscle, the long bone, will grow a little bit faster than the muscle itself that's attached to it. And so if already they had decreased knee extension because their hamstrings were tight and there was a lot of tone in there, as they grow, that's probably going to get worse. So you got to really focus on stretching those muscles as their bones are growing so quickly, because the spasticity and the tightness of the tone often gets worse before their growing kind of levels out or plateaus and they're able to get back to their baseline. So it's really important to continue to stretch during that. Community integration and a plan for adulthood is huge. Starting to think, what are we going to do once they graduate high school? Is there a program or is there a job or a pathway that we can help them find to, live the life that they want, that's fulfilling and full of purpose and gives them, some independence. So that's really key in this stage, is starting to, and we don't necessarily help in that planning process, but giving them some resources or pointing them towards somebody who could is very helpful. Something to keep in mind as far as fitness and overall goals: people with cerebral palsy, if they are sedentary, are at a much higher risk for becoming obese because of the decreased mobility. And then, of course, once you have more weight that you are carrying around, it's harder to move, it's harder to be transferred, but also you're more likely to have skin breakdown, pressure sores, all these things. And so movement is huge for somebody who has cerebral palsy. And even if they are paralyzed in the legs and can't use it at all, moving the arms and doing some type of cardiovascular arm fitness or anything like that would be still helpful. And keep in mind too, they may want to go to the gym, they may want to play a sport, they may want to, go wherever with their friends, and the areas they're wanting to go may not be accessible. So that's something that if you've never had to deal with that, you don't even notice what places you're going to are accessible and what aren't. But once you start to, really look at that, there's a lot of places that still aren't accessible, way less than there used to be, thank God, but a lot of places that still aren't accessible. All right, final stage, we're almost done, is adulthood. Of course, the goals are very similar in adulthood: independence with mobility and with ADLs, but also living a healthy lifestyle, community participation, possibly getting their driver's license or a job, or being active in certain community programs or groups, maybe in the independent living, having a family of their own, possibly working, all of those things. And so we want to help that however we can and help transition them into adulthood and into independence. And remember that, if there's any continued growth spurt, if there's any hormonal changes, if there's any this or that, their medications may have to be adjusted. They may have to do another episode of therapy. They might get tighter. They may have a setback. And so oftentimes they'll come back and get therapy for shorter amounts of time in adulthood because of certain things, maybe even injuries, and then return to their baseline. So that's more so when you're going to see adult patient with cerebral palsy. Final slide: medical management. There are different medications that can help with the spasticity. So Valium is one that can be given orally that could just help with general spasticity and muscle tone. Botox or botulinum toxin, which we all call Botox, is their injections. It's the same type of Botox that women get in their face, but they would put them in the hamstrings or in the anterior tib or in whatever muscles are really tight, maybe the triceps or the biceps. It just usually the biceps, the triceps are typically weak. And they might put injections in those specific muscles. I see them most often in the hamstrings and the hip flexors so that they can stand more erect, and it helps decrease the tone in those specific muscles where it's injected. But then you have to go and get those injections, once a week or once a month or however often the physician prescribes them. Some of the surgical techniques are a tendon lengthening, typically the Achilles tendon, if they are a toe walker or if they have a lot of spasticity in their gastrocs, then they'll get to a place where they cannot come down to a neutral position for their ankle to put their heel on the ground. And so sometimes they'll have to go in and do that procedure where they cut the Achilles tendon and lengthen it by pulling the two edges. So if it was like this, they would cut it right down the middle and then they would pull it apart and reattach it. The single event multi-level, what that means is where they are doing multiple surgeries at the same time. So they go in, they lengthen the Achilles, they might do something to lengthen the biceps tendon or something. They may go in and cut away some scar tissue or something from an old surgery. I don't know what all they would do. They may place a baclofen pump, but they're trying to do all the surgeries or several surgeries. It's really two or more, but several at the same time to decrease frequency of hospital stays, to decrease the episodes of rehab or therapy needed, so that they're able to just cover several things at once. Remember, though, when you do something like that, you have a lot to think about, because somebody may come in and be like, okay, now they're non-weight bearing on this, but they also can't use this arm. And it really gives you a lot of challenges when somebody has several surgeries at once, but it could be beneficial in the fact of only having to heal once. But I can't imagine how much pain they're in. So neurosurgery, selective dorsal rhizotomy. That's where they go in the spinal cord and they cut some of the dorsal roots. They selectively cut some motor roots while trying to leave some touch and proprioception nerves intact so that there is less spasticity and tone. This would be only done in somebody who has very significant tone, because it leaves them with significant weakness and balance deficits and lack of coordination. It can leave them with a lot of issues. It could leave them where they have no functional use of that muscle anymore, just depending. But it could help with severe tone and spasticity. And then a baclofen pump, it's typically surgically implanted right under the abdomen. That's that bottom picture there. And there is a catheter that leads from that medicine disc in the abdomen around to the spinal cord, so that baclofen can be pumped directly into the spinal fluid in order to decrease spasticity. So it gives you a continuous dosage of baclofen to the spinal fluid within the spinal cord, and it's controlled by a computer, so the dosage can be changed if needed. If it's too much or too little, then the physician can go in and change it. And then when that medicine disc is empty or when it's getting low, then they can go directly into that disc through the skin and put more medicine in, and then adjust it however they need to using the computer. What I have found in patients that have the baclofen pump, typically it works really well, but I will say one thing that I notice is you can tell when they're starting to get low. You can notice they're suddenly getting really tight. And sometimes I'll say, are you supposed to go back to the doctor soon to get your baclofen checked? Or, do you feel like your pump is still working well? Because sometimes, occasionally, the tubing that leads from the medicine disc to the spinal cord will get clogged. And so if all of a sudden you saw them on Tuesday and they were their They were a little tight, but they're normal toned. You could stretch them, they could move, they're normal. And then Thursday, they are tight and they are rigid and you cannot break them out of that pattern. I would say go see your physician. Make sure that you don't need more medicine or that there's not something blocking it because you're really tight today. So if you notice big changes like that, then I would send them back. All right. Thanks for joining me, and I will see you in lab.